Hey class, another disease of the respiratory system that we should talk about, we'd be remiss if we skipped it, would be tuberculosis. Tuberculosis is an ancient disease. There have been Egyptian mummies that have been found with tuberculosis. It used to be called a captain of men in death, or the White Plague. Tuberculosis recently is being re-emerging as a serious threat, particularly with pan-resistant or multidrug-resistant tuberculosis. In East Asia and in the Russian prison systems right now, there are some strains of tuberculosis that are quite terrifying. Right now on our planet, there's 2B with a billion people infected with tuberculosis. In other words, we have over 20% of the human population is infected with tuberculosis right now. In 85% of cases, TB or tuberculosis is going to be contained within our lung. Tuberculosis can manifest itself in a clinical setting as 3 different forms. We have primary, secondary, and extrapulmonary, or disseminated, leaving the lungs, so to speak. If we look at that primary or initial stage of tuberculosis infection, the minimum infectious dose of tuberculosis is about 10 bacterial cells. And that's effectively nothing. I mean, that's a droplet within the air, an aerosol droplet. These bacteria are going to be capable of multiplying within our macrophages. They actually prefer to multiply within our macrophages. And as they escape from macrophages, they will have a cell-mediated attack on our bacterium. These TB bacteria can be attacked while they are free-floating within our bodies, but they can hide and reproduce and, so to speak, rebuild their numbers while they're hiding within our macrophages. Within our lungs in particular, a growth known as a tubercle can form. These tubercles are going to be large masses of dormant bacterium, and neutrophils will release enzymes at these tubercles that can cause necrotic caseous lesions that will heal by themselves through calcification. So first the tubercle forms, then the neutrophils of our bodies attack the tubercle, and then that leftover necrotic lesion will calcify. We've also seen that T cell action can be initiated in response to tuberculin exposure. Here if we look at some cells and a tissue culture slide, or a tissue slide, also known as a histograph, we can see that there is a tubercle that's staining different from the regular granuloma cells of the lungs. This tubercle is effectively a large growth of infected cells, infected with the tuberculosis bacterium. And it will be destroyed by the neutrophils and replaced with a calcified mass, eventually. Tuberculosis can eventually leave the lungs and become extrapulmonary. So anytime that TB infection gets out of the lungs, we call it an extrapulmonary infection. They can leave through the regional lymph nodes. Occasionally it will manifest itself within our kidneys or the long bones of our bodies, sometimes the genital tract, and other times the brain and meninges. Correspondingly, that is known as renal tuberculosis, genital tuberculosis, or tubular meningitis. If the patient has a suppressed immune system, maybe they've received an organ transplant, maybe they're very young, maybe they're very old, maybe they have HIV/AIDS, they are going to exhibit these extrapulmonary conditions of tuberculosis. In most situations, 85%, tuberculosis is going to be contained within the lungs. Untreated tubercular meningitis has approximately 30 to 50% mortality rate. This is a very serious condition. Once those tubers start to form within the brain tissue, and then they're destroyed and replaced with calcified tissue, it's not very good for the patient. We also have secondary or reactivated tuberculosis. We can have live bacterium that can remain dormant for very long periods of time and reactivate. This results in chronic tuberculosis. Those tubercles, instead of being calcified, after being destroyed by the neutrophils, can actually expand. Some severe symptoms can start to develop as these tubercles are expanding, one of which is consumption. Consumption in this case is a violent cough that has some greenish, bloody sputum coming out. It also is going to be associated with low-grade fever, weight loss, extreme fatigue, and chest pain as these tubercles are growing inside of the patient's lungs. untreated secondary tuberculosis has a 60% mortality rate. Ay caramba, that's pretty high. The bacterium that causes tuberculosis is Mycobacterium tuberculosis. This is a bacterium that's acid-fast. It's a strict aerobe. It must have oxygen, and it is incredibly slow growing. When culturing Mycobacterium tuberculosis for students in an undergraduate setting, I would use non-pathogenic strains, and it would typically take a week to get a good culture on a petri dish, as opposed to 12 hours with most other bacterial species. These bacterium have lots of mycolic acids in their cell capsules and cell walls. These mycolic acids and waxes make it very difficult for the bacterium to be destroyed after being phagocytized. After a macrophage phagocytizes a tuberculosis bacterium, the phagosome fuses with a lysosome to form a phagolysosome. And normally, if there wasn't that thick, waxy coating on the outside of the bacterium would be destroyed. But TB is designed to live inside of the cells that normally destroy it, and it has that thick, waxy coating which allows it to do it. Because of the thick, waxy coating, it's also very resistant to drying out, desiccation, and also resistant to disinfectants. And if we look at tuberculosis, there's a core factor on Mycobacterium tuberculosis, which has been linked to the virulence level of that particular strain of tuberculosis. In HIV/AIDS patients, Mycobacterium avium is a primary source of infection, and Mycobacterium bovis is a primary source of infection from unpasteurized milk. But these species, Mycobacterium avium and Mycobacterium bovis, are not as dangerous, not as pathogenic as Mycobacterium tuberculosis. If we look at our pathogenesis and virulence factors for tuberculosis, that thick, waxy cell wall makes it really tough to kill. It also is going to stimulate a very strong cell-mediated immune response. And this very strong response enhances the disease pathology. Tuberculosis is primarily transmitted via respiratory droplets or aerosol droplets. When a patient is coughing up that greenish sputum with blood, that's when they're transmitting the disease. Tuberculosis can survive for 8 months in the air as a fine aerosol particle. That's an incredibly long time. We can influence our susceptibility for tuberculosis, though. If we have inadequate nutrition, if we have a debilitated or immunocompromised condition, if we have poor access to health care, lung damage, or genetic predisposition, we may be more likely to contract an infection and a disease state. Tuberculosis, generally speaking, is going to be known as a disease of poverty. In the year 2013, 1.3 million people died from tuberculosis alone. And of those people, there is a disproportionately high number of them that are in the developing world or in third world countries. Within the United States, 60% of TB cases are among individuals that were foreign born and then came to the United States. Individuals in the United States who work for nursing homes, hospitals, jails are at increased risk or higher risk. And this is one of the reasons why most of you have had that TB test before you started going through your clinicals. Clinical diagnosis of TB relies on several primary techniques. The Mantox or tuberculin test is the most common one. This is a test that errs on the side of giving false positives. We also have, if we get a positive with the tuberculin testing, we'll then follow up with a chest x-ray. We could also follow up with a serological blood testing. We could do some culturing of the patient. We could do acid-fast staining from sputum samples of the lungs. Or we could do polymerase chain reaction to identify the specific genetic strain or serotype of Mycobacterium tuberculosis and identify any drug susceptibilities with a Kirby-Bauer assay. The tuberculin test is typically performed when a small amount of tuberculin protein is injected in the dermis of a patient, and then 48 to 72 hours later, we go and check the results. If there's a red, swollen bump on their skin, 2 to 3 days later, they're going to be positive. And depending on the category the person's put into, category 1, 2, or 3, the severity of the response is going to be measured to indicate whether or not they are positive. The small raised bump that it forms after the tuberculosis testing is known as a bleb, which is one of my favorite words in microbiology. Look at that, bleb. Bleb. It's a fun word to say. If you get a positive result with the skin test, you need to follow it up with a lung x-ray. That skin test errs on the side of false positives, so we need to do the lung x-ray just to double check. Here's a chest x-ray of a patient who has those tubercles growing in their lungs right here. That's present as that milky white growth. Compare that to their left lung, which is completely clear on their superior lobes. If we look at some histology, we can see that the tuberculosis bacterium, Mycobacterium tuberculosis, stains acid fast. And if we look on this figure right here, we can see, I should probably go with a color other than red. We can see the results of our staining indicating the presence of this bacterium. Generally speaking, the best way to prevent contraction of tuberculosis is to not get exposed to tuberculosis. Limit your exposure to infectious particles. If the patient is actively coughing, you should isolate the patient, put the breath mask on the patient, and put the patient in a negative pressure room. There is a live attenuated vaccine for tuberculosis, but it's not currently used in the United States. It's based off of the bovine tuberculosis bacterium. Individuals that have been vaccinated with this bovine tuberculosis bacterium are going to give a false positive to the tuberculin tests and will require that follow-up chest x-ray. Let's say somebody has TB, but they aren't experiencing the symptoms of TB. They have latent TB. The TB bacterium are busy hiding in the macrophages. We can treat the patient with rifampin and rifapentine, and this is going to be a 4 and 3 month treatment, respectively. 4 months of rifampin, and then 3 months of rifapentine, and then that can be followed up with a 9-month treatment of isoniazid. If the patient has active TB in their body, they are going to need to receive additional antibiotics, including ethambutol, pyrazinamide, and in addition to the rifampin and occasionally the rifapentine treatments. The biggest problems with TB therapy is non-compliance. You have to take your pill every day for up to 9 months. So the better part of a year, you need to take a daily pill. And the problem is, first of all, affording the pill, obtaining the pill, and then remembering to take the pill. Many times patients are non-compliant and develop an antibiotic-resistant or multidrug-resistant form of tuberculosis. Something that wasn't necessarily mentioned in your textbook, but is also making waves right now, is pan-resistant TB. There are some strains of tuberculosis right now that are resistant to every known antibiotic. We have nothing that can treat it. Those are the ones that really scare me. Now, if we look at these multidrug-resistant strains of tuberculosis, they need to be resistant to at least iazinid and rifampin. So they need to be resistant to the 2 most common drugs. This means that the patient needs to be treated for approximately 2 years with 4 to 6 drugs. And it's very common in people who have been previously treated for tuberculosis. If we look right now worldwide, 20% of cases of tuberculosis are multidrug-resistant TB. Depending on the part of the world that you go to, that number can be as high as 60%. Individuals that have multidrug-resistant tuberculosis are very much sicker and they have higher mortality rates because that pathogen is much more virulent and it's much more difficult to fight off, especially if you compare them to individuals that have non-multidrug resistant tuberculosis. These multi-drug resistant TB strains are typically going to be resistant to 2 additional drugs in addition to the 2 minimum. So typically multi-drug resistant tuberculosis is going to be resistant to at least 4 antibiotics. We've found multi-drug resistant tuberculosis in 84 countries. Oop, I stand corrected. My bad. 9% of multi-drug, 9% of cases of tuberculosis are going to be 9% of TB cases are going to be worldwide are multi-drug resistant TB cases. Individuals that have multi-drug resistant tuberculosis have very few treatment options. The classic medications, the chemotherapies that we'd offer them are no longer effective. Individuals that have our multi-drug resistant strains of TB have a 70% mortality rate within a couple months of diagnosis. Right now, India and China have the highest burden of pan-resistant, or XDR, TB. So, tuberculosis is a disease caused by the bacterium Mycobacterium tuberculosis. I want to emphasize that this bacterium is transmitted via the air, and it lives for a very long time in the air, and it's very difficult to destroy because it has such a thick, waxy coating in its cell envelope. Within the United States, most cases of tuberculosis are going to be just a generic form of tuberculosis, with approximately 10,000 cases a year of tuberculosis in the United States. Of the cases of tuberculosis that occur in the United States, less than 100 per year are multi-drug or pan-drug resistant tuberculosis. If we break down the demographics, only 16% of whites, or only 60% of cases of tuberculosis in the United States are in whites, and then the remaining 84% are in ethnic minorities. So there's a disproportionately large amount of TB cases within minority demographics. That's all we have on tuberculosis. If you have any questions for me about tuberculosis, please feel free to post them in the class discussion board or shoot me an email. Happy studies.